Hi, I'm Dr. Chris Stevens, and this is the Psychology to Live By podcast. Our guest today on Psychology to Live By is Dr. David Clarke. He's the president of the Association for the Treatment of Neuroplastic Symptoms, a non-profit dedicated to ending the chronic pain epidemic. Dr. Clarke holds an MD from the University of Connecticut School of Medicine and is board certified in internal medicine and gastroenterology. His organisation's mission is to advance the awareness, diagnosis and treatment of stress-related and brain-generated medical conditions. As the host of the podcast, The Story Behind the Symptoms, Dr. Clarke delves into origins of people's unexplained symptoms. And you can also learn more and lean into this information more at the website symptomatic.me. But the backdrop to our discussion today is the epidemic of chronic pain and chronic illness around the world. It's estimated that 1 in 6 adults suffers from chronic pain or illness that's either medically unexplained or unresponsive to virtually any treatment. Many of these patients have neuroplastic symptoms, defined as brain-generated conditions linked to past or present stress, trauma or emotions. And these chronic symptoms manifest themselves in many, many ways as fibromyalgia, migraines, irritable bowel syndrome, long COVID, chronic back or musculoskeletal pain, and many, many more conditions. The experiences with conventional diagnosis and treatment leave most people with neuroplastic symptoms feeling somewhat neglected by the medical profession and hopeless about their future. And this brings me to Dr. David Clarke. Welcome, Dr. Clarke, or I'll call you David. It's wonderful to have you on the podcast. I've been really looking forward to this conversation, and I'm sure it's going to be a real highlight for our listeners.
Thank you very much, Chris. It's great to be with you. I worked as a visiting professor in Brisbane about 30 years ago, and so I always feel a connection with any time I talk to an Australian.
Fantastic. Well, I actually live about 2 hours south of Brisbane. I live on the north coast of New South Wales. So there you go. So you'll know how hot it can be in summer.
Oh yes, it was. It reached 44, I think, just before we left. But we spent some time in the heat, body surfing in Byron Bay, and always remember that.
Well, that's where I live, 10 minutes from Byron Bay.
Yeah,
Yeah.
beautiful area.
So there you go. Yeah, I'm very lucky. All right, but let's dive in. We have so much to talk about. It might be interesting, I think, just to start with a brief background on what's led you from, being a doctor of gastroenterology to, the champion of this cause around neuroplastic symptoms.
Yeah, it was completely unexpected, Chris. I mean, for the first 7 years, I received just completely traditional Western training in medicine, which essentially means that you're taught that if this person has pain or illness, they must have a disease or a structural damage to explain it. And I was doing very well in that world. I got an award for excellence in medical school. I got into my dream hospital residency program. So the last thing I expected was to encounter a patient that I didn't know the first thing about diagnosing or treating. And especially when that happens in the 8th year of your training. By the time you get to year 8, you think you know everything. So to see a patient, and this woman, 37 years old, she was averaging 1 bowel movement per month. Despite taking 4 different laxatives at double the recommended doses every single day. She'd already been evaluated by another university. They couldn't find anything wrong with her. She came to us from them to get some specialized testing that my department chair and I were convinced was going to show the problem because as far as we were concerned, no other explanation was possible. This had to do with the neuromuscular ability of her large bowel. But that test was normal also. So it was left to me to do an exit interview with her and just essentially tell her, very sorry, but you're going to have to live with this. But we kept talking, and at some point, she trusted me enough to share that she had been abused as a girl, um, hundreds of times, in fact, sexual abuse by
No.
her father. And
Mm.
this was not something I had been trained to ask about, not something I had been trained how to respond to. And I certainly didn't think it could be connected to her illness, but it gave me something positive to do, which was to refer her to a psychiatrist whom I didn't even know, but I had heard that she was interested in these mind to body conditions. And I never thought for a moment that anything more than just helping the patient live with it would come out of this. So I forgot all about her until 3 months later. I ran into Dr. Kaplan, the psychiatrist, in an elevator. And between the ground floor and the fifth floor, this was the lift ride that changed my career because she told me she had cured this patient with less than 3 months of weekly counseling sessions. And I had never heard that such a thing was remotely possible, that you could alleviate a real and a serious physical condition just by doing psychotherapy of a particular type. This is not cognitive behavioral therapy,
Mm.
this is
Mm.
something quite different. But it just shocked me. I never thought I would be able to make use of this myself, but I did decide that, if I'm going to be a complete doctor, I need to learn how to do this. I might see a patient or two every now and again that needs this. So I learned the basic framework from Dr. Kaplan, went into private practice, started asking the questions she had taught me whenever I saw a patient whose diagnostic tests were normal. And I was finding 5 or 6 patients a week with these brain to body conditions. And I was beginning to be able to help people recover from them when they had mostly failed elsewhere in the healthcare system. And I found this very rewarding. I kept doing it. And now, 40 years later, I've seen over 7,000 patients with this, written books with colleagues, founded the nonprofit. I give lectures all over North America and Europe, and some by Zoom to your part of the world.
Yeah.
It's just uh, been tremendously rewarding part of my career.
Well, it's a great story, and it's going to resonate with so many people because, as you know, there's so many people who've done the rounds of failure to diagnose and failure to diagnose, and or been accused that it's all in a pejorative psychosomatic. It's in your head,
Yeah,
right?
that
And
you're imagining this, or you're neurotic, or you're too weak to handle the
yep,
normal stresses of life,
yep,
and that there aren't that many of these patients around out there, that physicians can't really deal with it. It's not even in their
yep,
job description. These are all they're worse than myths. I mean, the truth is the exact
yeah.
opposite of these things.
Exactly. And so, as I say, I think there's going to be a lot of people that'll be on the edge of their seats because they're going, "Oh, hang on, this sounds like me, right?"
Or a loved one, yes.
Or a loved one, or a friend, and so I think that's fascinating. And I remember talking to a good friend of mine who's a chiropractor, and he was telling me about MRIs and about how there's basically no correlation between the structural damage in spines and people's level of pain. You can have people with perfectly good looking scans and they're in terrible pain, and people with shocking looking spines and they're pain free.
That's
And
absolutely right. Yeah, there's a famous study where they looked at several thousand people who had no pain at all, and they scanned their backs, and over half the people over the age of 40 had abnormalities.
yeah, yeah. Well, I think it's called getting older, isn't it? Like it's
That's
like
what it is. It's basically the same process that produces gray hair, which is something you and I have familiarity with.
or no hair, as the case may be. Um, Yeah, so and I remember I had a back injury, like a proper back injury, a disc bulge. It was an accident, and the best physiotherapist in the region told me that I would never lift more than 20 kilos and that I'd be living this with the rest of my life. You know, it terrified me. Fortunately, he was wrong. Um, and so, you know, I think there's just going to be a million stories out there. But I think let's dive in now to what are neuroplastic symptoms and how do they differ from those that are, you know, clearly caused by some sort of injury or illness and so on. How do
Yeah,
we distinguish them?
yeah, the neuro part refers to the brain and nervous system, which are actually the nerve pathways are physically altered in this condition. And we know that from MRI studies of the brain in people who have these. And these conditions are highly varied. The nerves go everywhere, so the symptoms can appear anywhere. Migraines, tinnitus, which is ringing in the ears, dizziness, pseudo seizures, visual disturbances, trouble swallowing, brain fog, chronic fatigue, many cases of long COVID. The spine we've talked about. A colleague of mine did a study of over 200 people with back and neck pain and found that 88% of them, it was not due to a structural cause and instead was what we call neuroplastic. The plastic part of the term refers very hopefully to a capacity for change because we can treat this condition successfully and actually alleviate these symptoms. So it's brain generated symptoms, which begs the question, why is my brain doing this to me? And the reason has to do with the reason why the nerve pathways are changed, which is connected to stress, to trauma, to unrecognized emotions, to the long term impact of childhood adversity, which can manifest in a variety of different ways, and essentially to any major challenge in life that isn't currently being successfully coped with.
And that could include initially some sort of physical damage, right? Like as in my case, an accident with a disc bulge that was extremely painful.
Yeah, it
But
can
then
start that way.
that's right. But then it shifts, and in my reading, I've seen evidence, you know, functional MRI evidence that the when you take a snapshot of the brain, the picture of the parts of the brain that are activated from the actual physical damage shows a different picture to the chronic pain. So maybe 2 years later, that in fact different regions of the brain are processing neuroplastic pain than may be processing the original um, physically caused pain. Is that right? Have I expressed that?
Absolutely right. You've got it spot on. The part of the brain that becomes active in acute pain, gradually in those destined to develop chronic pain, the activity shifts to completely different areas of the brain that have to do with emotions and with the making of meaning uh,
And
and
memory?
and memory.
Yeah.
Absolutely, yeah. So this is a completely different condition when it becomes chronic.
This is so interesting, isn't it? And maybe we should just do a little dive here because I think that my audience will be interested in this. In thinking about the brain as a sort of predictive processor. So in other words, I think our naive view of the brain is, you know, or sight is that it's a sort of passive registration of all the sense data, you know, so that and but it appears it doesn't actually work like that. That is that we have a lot of feed forward mechanisms in the brain. So, for example, I can't remember the exact numbers, but there's a lot more brain pathways that go to the visual cortex, a lot more from the brain to the visual cortex than from the eyes to the visual cortex. And that in other words, the brain is like a simulator and it's constantly predicting and then it's checking data to see if the prediction is correct. Uh, I'm just be fascinated to know what your thinking is about how these neuroplastic symptoms reflect that nature of predictive processing and simulation.
Yeah, it's constantly predicting because it's something in your immediate future that could kill you. So
Yeah,
its priority is to keep you alive. So it has to,
yeah,
it's living inside your skull, and its only contact with the outside world is through the sense organs. So it has to take all this information and integrate it and try to predict, what's coming next, and especially what might be coming next that's a threat to you. And
Yes.
sometimes, if you've been affected by issues I mentioned earlier,
Yeah.
psychosocial stresses and traumas and emotions and so forth,
Yeah.
it will kind of make a mistake, and it will start to believe that there's threats out there that aren't actually there, and it can start sending signals into your body that are in response to that, and then your body reacts by developing symptoms, and you don't know what's going on consciously. This is all happening beneath the surface, and your body suddenly develops pain, or irritable bowel syndrome, or fibromyalgia, or pelvic pain, genital pain, muscle spasms, um, all of those things. And it's quite natural that you're going to have some fear around, what's happening to my body? Am I going to be disabled? Is there some serious condition going on in there that's going to be causing this? And then the fear amps up what the brain is doing, and you get into a vicious cycle, and it can put people in the hospital. It can
Yeah.
last for years or decades. My personal record patient had neuroplastic symptoms for 79 years.
Oh my God.
Um, Another patient of mine had unexplained abdominal pain, 17-year-old girl. She had this pain for 18 months. She'd
Yeah.
seen 6 other gastrointestinal specialists. When I was asked to see, and with no explanation, when I was asked to see her, she had been in the hospital for 70 straight days, getting massive doses of morphine around the clock.
Yeah.
These are 100% real symptoms, every bit as severe as those caused by anything else. But the process is 100% in the brain. One last example I can give that I think probably most of your viewers are familiar with is phantom limb pain, where
Yeah.
somebody's had an amputation and they feel pain at the place where the limb used to be. But
Yeah.
and it can be very severe pain. But the limb is not there anymore. So where is the pain coming from? It's brain generated.
Yeah. And yeah, like my mind is buzzing because, everything you're saying, I map it onto the psychotherapeutic world. And there's a lot of psychic pain that mirrors exactly what you're talking about, where people's perceptions of themselves or the perceptions of the world um, are just one series of false alarm after false alarm after false alarm, but they don't know it's a false alarm because it feels so real.
Yeah, it
Uh,
absolutely feels real. There's a famous picture in the British Medical Journal from about 30 years ago of a construction worker who impaled his boot on a nail and was instantly
oh,
in agonizing pain, was rushed to the emergency room, given morphine intravenously, and then the boot was carefully cut away, only to reveal that the nail had passed neatly between his toes, and he had not a scratch. So again, that was the brain taking in the information from the world and making a decision about whether it was going to give you a pain signal or not. The other
yeah,
side of this is that if you whack your thumb with a hammer, you don't get actually a pain signal from your thumb. You get a damage signal, and your
yeah.
brain has to then decide if you're going to experience pain in your thumb or not.
Which is absolutely incredible if you think about the implications as you have done. I mean, it reminds me to a bit of parenting. When you have a toddler and they fall, and the parent's response then is critical. Like
Oh my
if the
God, you fell! I've got to help you.
you must be in
This
pain.
is terrible. That looks awful. Oh my
Yeah,
God!
exactly. And
And
of
of
course,
course,
what's the kid going to do? They're going to be in great pain. They're going to cry a lot. But if the parent is, wow, that was a great fall, let's see if we can do another one. The kid gets a message that, um, oh, it's nothing to worry about, and 99 times out of 100, it is nothing to worry about. There's no organic damage. The only thing maybe hurts pride, So, all
another
right,
good
so,
example along these lines is somebody who sprains their ankle while running from a predator, and your brain will probably decide that you don't need to feel the pain of that
Yes.
ankle until you reach safety.
Yeah. I used to play rugby, and you play out the game with an injury because you're adrenalized, you're super motivated, and then 5 minutes after the game you can't stand on that ankle, right? So we've traversed a little bit here how the mind affects the body and the body affects the mind. Um, so I think what might be useful now is to think about, um, well, first off, how do people distinguish? Like, how do I know that my back pain is not being caused by an exposed nerve being trapped and actually sending pain signals to my brain, and it being a neuroplastic symptom?
Yeah, the simplest answer is to have your physician evaluate you and see if
Yeah.
they can find a structural damage or an organ disease to explain it. But there are
Yeah.
some other clues. On the symptomatic.me website, we've got a 12-question self-assessment quiz that
Great.
people can do that to screen themselves. The more questions to which you answer yes, the more likely it is that your condition is neuroplastic. But some other clues are that if you have more than one symptom, and you've had more than one symptom for longer than 6 months, especially if the symptoms are in widely disparate locations or have different qualities to them. I heard about a patient today who had difficulty swallowing. She had Raynaud's blood vessel spasm in her fingers, and she had a functional neurologic disorder. So the fact that she had all three of these and that they're quite different from each other makes it highly likely that hers were neuroplastic. In
Yes.
the spine, when it comes to pinched nerves, we can take some comfort in the fact that the study showed 88% of back pain, back and neck pain, is neuroplastic. If there's actually a pinched nerve, it's going to cause neurologic findings, let's put it that way, that there's going to
Yeah.
be numbness of the skin in an area of the skin that corresponds to where a particular pinched nerve will go, or
Yes.
muscle weakness, or bladder or bowel problems, or loss of reflexes, some kind of physical change that the
Yeah.
physician can identify. And if they don't identify any of those things, then very likely it's a neuroplastic. Another one is if the symptoms move from place to place.
Yeah.
Patient of mine, evaluated by an otherwise excellent colleague of mine, had abdominal pain, and he did every test you can think of for abdominal pain and found nothing. But her pain was moving from corner to corner of her abdomen on different days. It'd be in the left upper corner one day and the right lower corner of the abdomen on another day. Tumors and infections and inflammation, uh,
They don't do that.
they don't do that.
No.
So I asked her, are there any stresses in your life that correspond to the 8 or 9 months that you've been having this pain? And she was suffering domestic violence 2 or 3 times a week from the partner that she was living with. And this had
Yeah.
been going on for a period of time exactly corresponding to the duration of her symptoms. But none of her doctors before then had asked her about this.
This is so interesting. I was very fortunate early in my psychological career. I got some excellent training in solution oriented hypnosis, and the idea is uh, 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 the idea is that you want to treat the whole person, and that includes the way the mind and the body are really just two sides of the same coin. We shouldn't really be distinguishing. And so what I'm thinking about now, and maybe a little segue, is I'm now thinking about all of the wonderful doctors out there and surgeons and specialists. Uh, they must, that like you, they'd be confronted by, they've done all the proper tests and they can't find a cause. So now the question has to be, I wonder if it's neuroplastic. But of course, they haven't had that training. Is that right?
That is correct. And that is why my colleagues and I founded the nonprofit. That's our mission, is to
Yeah,
educate healthcare professionals and the public that this is a third possibility. If the
yeah,
structures are okay and the organs are okay, you have to think about a neuroplastic process because it's 20%, one in five of the adult public. And it's two out of five of everybody that goes to see their primary care doctor about a symptom.
yeah. So now, then in my mind, my simulating brain is imagining what those practitioners are going. But I'm not a therapist. I've been trained in organic chemistry and biomechanics and whatever. I don't know how to do psychotherapy. So what's the answer there?
Yeah, the answer there is just to screen for it. We're not asking people
Yeah,
to treat these issues. That falls into your territory, and the best outcomes are achieved when people with my background uh, work collaboratively with people with your background to give the patients the care that they need. But just asking people some simple questions: Did anything stressful happen to you at the time your symptoms began?
yeah,
Are you having any stress issues in your life at the moment? Did you go through anything as a child that you would never want for a child of your own, or that would make you sad or
yeah,
angry to witness? And reassuring people that symptoms that are generated by this process are, in terms of their being real, they're no different than symptoms from organ disease or structural damage. And people are very willing to share when they see that you, as a medical professional,
yeah,
are interested in this from a diagnostic standpoint. You're taking it seriously. You're not dismissing them. You are looking for the real answer to their problem. They're very accepting of it. And then when you uncover some of these things, you don't have to treat it yourself. You can just say, oh, well, we've uncovered some issues here. I have a stress expert. His name is Chris Stevens. All you have to do is go to Byron Bay and he will take care of you.
I'm trying to retire. Thank you very much for that one, David. But
We have 50 million Americans that are going to be on their way.
uh, it reminds me of something. This is a little bit tangential, but you might be interested in it. I've done a very significant portion of my career has been consulting into business,
Oh,
especially in relation to mental health in the workplace. And there's been a sea change in Australia and elsewhere, much more awareness about the importance of mental health and the impacts of mental health. And like that checklist that you were talking about that the medical practitioner could have, it's kind of similar now. Some of the stuff we used to teach managers is they might be performance managing someone because their performance has really declined or their behaviors have turned bad towards other people. And the difference now is that there's been a lot more psychoeducation, just culturally, but also for HR people, human resources people. And so now they have some questions in their mind if it twigs, oh, the decline, they're normally a good performer. Um, there could be another reason for the decline. It may not be they're bad people. It may not be that they're I don't know, lacking motivation or whatever. And so then it's a question about, is there anything else going on in your life? Are there other stresses? You don't need to give me all the details. So just asking that question, then they have, very often opens up a referral possibility to the employment assistance program or an independent psychologist. And it is really amazing what happens then because uh, people get to deal with the real problem and their performance takes care of itself once they've dealt with a psychological problem. So it's very, you can see the parallel, I take it.
yeah, that's a great model, and it absolutely is in parallel. And people in business should absolutely be paying attention to this neuroplastic condition because it clearly affects ability to perform in the workplace.
Yeah,
And it's often linked to ACEs, adverse childhood experiences, that
Yeah.
along with the neuroplastic symptoms, can also produce personality traits that can be problematic in the workplace.
Yeah.
And if these things are uncovered and the links between them are understood, and people get the care that they need, the insight that they need to successfully overcome these issues, they become much more productive in the workplace and
Yeah.
in the rest of their lives. That's one of the beautiful things about this work is you're not only alleviating symptoms, but you are changing people's lives in many other ways as well, as you very well know.
I know, and I mean that's what keeps us coming back, isn't it? Because it's not necessarily always easy work. But I think it's really important now that we talk about what neuroplastic recovery therapy is. So I think people are going to be very curious. They say, okay, so now we've identified that this might be neuroplastic. What do you do to them?
Okay,
What's yeah,
there are several layers of this, and there are a couple of different subtypes of neuroplastic recovery therapy. But the very simplest concept is to shift your focus from your body, where the symptoms are, to your mind. Once the physician has determined that there's no organ disease or structural damage that's responsible, that's a great relief. That tells us that you don't have to be worried about some mysterious condition lurking in there. You don't have to be worried about permanent long term disability. You can take the fear level down about those things and then instead view the symptoms as a form of communication, that your mind is trying to tell you something in the only way that it can right now, which is in the form of symptoms in the body, pain or illness. So you shift your attention to the mind and start thinking about what your mind might be trying to communicate. What kinds of stresses are happening in your life right now? Um, what might have happened that was traumatic, say, at the very beginning of your symptoms that could have set them off? What kinds of adversity did you go through as a kid, and what effect has that had on you long term? And when people start to think about these things, they become more consciously aware. And those become ideas that we can address therapeutically. One of the biggest is unrecognized emotions. Many of my patients are like dormant volcano. I'm sure many of yours too. Dormant volcanoes on the outside with boiling magma on the inside, and it may be anger or fear, but also shame, grief, or guilt. I've seen all of those be responsible for physical symptoms in some people. And if we can help people recognize those, one of the techniques that I used to use a lot, almost with everybody, especially those with the ACEs or adverse childhood experiences, was to have them imagine a child of their own or a child they care about growing up exactly as they did. To imagine themselves, for example, a butterfly on the wall of their childhood home, and they're only able to observe, and they have to observe their own child or another child that they care about growing up in that home and trying to cope with it, let's say for just a week. And many of my patients, when they start imagining that, they're horrified. They may have initially told me, things weren't that bad.
yeah,
I think I'm over it. Other people have been through worse. But when they think about their own child going through the same things, they would find it difficult even for a week. And these are people who went through this experience for, in round numbers, 1,000 weeks.
yeah,
And I asked them to do this exercise first to get the reality of what they experienced. And then, second, to realize, there may be some emotions going on around this that you had to bury when you were growing up. But now your mind is trying to let you know that they exist. It's trying to express those emotions via your body. And we need to figure out what those emotions are and start talking about them and writing about them. Another exercise I have people do is write an unmailed letter to the person who mistreated them as kids. Not to
yeah.
mail it, just
No,
to
don't send
write
it.
it. And then the emotions get expressed in words. And the more they're expressed in words, the less they need to be expressed via the body.
So interesting, and obviously that a burgeoning field in my in my industry is, self-compassion and compassion-based therapy. And what you're describing there is very often people find it easier to feel and express compassion to a third party, but find it hard to apply to self. So that we're looking for, just little sleights of hand, as it were, little ways that the person can actually use their capacity for compassion, but now apply it to self.
Yes.
In this way of thinking about myself as a child.
I'm so
And
glad to hear you say that because I don't hear it emphasized nearly enough in the mental health community that one of the benefits of this exercise of imagining your own child growing up as you did is to have some compassion for that child and even more than that, admiration for that child. That
yeah,
they've demonstrated in many of my patients' cases heroic perseverance to have come through these experiences. And if my patients can start thinking of themselves in those terms, it often represents a
yeah,
complete flip in their self image. And that's a massively good foundation for their further recovery.
yeah. And the other thing that occurred to me is you're also flipping this around a little bit. And what I'm thinking about here is a sense of agency. So the key thing that struck me about people with chronic illness and chronic pain, especially when they've done the rounds of the traditional medical system, they might have even had operations that didn't work or made things worse. They start to develop a sense of helplessness and hopelessness. And, there's just something wrong with me. There's something fundamentally wrong and it can never be fixed. And what you're giving people is this sense of agency and hope. It's like, well, there's actually something I can do about it. And I'd imagine the psychoeducation is a really important part, like teaching them about neuroplasticity, teaching them about neuroplastic symptoms, educating them the fact that if you practice something a different way and you pair it with something more pleasant, as in like exposure therapy,
Hmm.
like if you can calm a person down, expose them to the feared thing, they begin to retrain the neural circuits into a sense of safety rather than danger. So
Yeah.
could you just speak to that a little?
Yeah, absolutely. The nervous system regulation, so that people who grew up in the moral equivalent of a minefield. They have to
Yep.
be constantly vigilant, and they carry that sense with them long into the adult years. Can obviously contribute to anxiety disorders developing. So that if we can teach people to bring the arousal level down, show them, where that hypervigilance came from in the first place, because again, they were growing up in a place where some days everything was fine, other days things were not at all fine. And so they had to be constantly watchful. So helping people understand that can definitely lead to the arousal level being brought down. But another way that it can be beneficial to make all the changes that we're talking about is when the parent or parents who mistreated the child are still in the lives of the adult patient. And they had never learned how to set boundaries with that person because it was their parent and they were dependent on them and they
Mm,
were
mm,
constantly in their presence. So they never learned how to uh, manage the level of trauma or abuse or whatever it was um, as kids, and they still don't know how as adults. But if we can empower them through that thought experiment that I mentioned earlier, help them to feel their own heroic perseverance, give them that foundation of self-esteem, then they can feel empowered to say, you know what, I don't deserve to be triggered by this person anymore. I feel empowered to set some boundaries around this person so that they
yeah.
are going to stop traumatizing me. That's huge for a lot of my patients.
Yeah. And again, there's lots of different psychotherapeutic paths to that, like internal family systems, of course, would be looking at this kind of thing. Um, and, mindfulness based practices are no doubt an important part, compassion based practices, cognitive behavioural therapy. I'm starting to see now how all these little pieces can fit together. But basically, you're looking at people first off having some confidence that there's something that can be done. Now, just on that issue of confidence, I remember reading about the Boulder study on back pain. I think that might be very useful to give our listeners, especially those who are suffering from the conditions we're talking about, a sense of really empirically grounded confidence that we're not talking about woo-woo, crazy stuff.
Yeah, you're absolutely right. I don't want to leave people with the impression that this is just me and my stories about patients, because we now have uh, truly gold standard science, randomized controlled trials that document the benefits of this from at the moment all across North America, everywhere from Halifax to Los Angeles. But the Boulder back pain study was one of the early ones and still one
Yeah,
of the best. They took 150 people with back pain for an average of 10 years, divide them randomly into three groups. One group got their usual care, nothing special. Another group got an injection into the spine, which is a pretty powerful form of treatment.
yeah,
And then the third group got one of the new types of neuroplastic recovery therapy. Only 2 sessions a week for 4 weeks was all they got.
so
Uh,
8 sessions.
8 sessions.
Yeah,
And the pain scores dropped in the NRT group, neuroplastic recovery therapy, by 75% in 4 weeks. And the other two groups, hardly a slight drop, but barely significant. So nothing like that had ever been seen before from talk
yeah,
therapy. I mean, people had tried cognitive behavioral therapy, and it really doesn't work very well because you're
yeah.
not dealing with the key issues. But with this, 75%, and then they stopped the treatment and they followed the patients for another 11 months, and the pain levels, the pain scores stayed down, even though they weren't getting any further treatment. And they've
Okay.
just published 5-year follow up, and there was a slight return of the pain. I think it came up to maybe a 60% improvement from the baseline. But this is after 5 years of follow up from
And can I
a
ask,
treatment that was 4 weeks,
and there has been no intervening treatment. Uh,
no intervening treatment.
uh,
They
I
they
mean,
just
it's
went back
hard
and
to
checked in with them.
it's hard to convey how unusual a finding like that is in a randomized controlled trial when you're dealing with persistent and treatment resistant conditions of any kind. You'd be happy with a 10% rate, right? Like that would
You
be,
you could publish the study if that's what you got. These people had been in pain for 10 years.
yeah,
And it just, you just have to imagine 10 years and then boom, 75% drop in 4 weeks.
yeah. And so, I think this is, and I know that you've got a survey. You're currently running a big survey across the
We
Americas.
did it. Yeah, we did a nationally representative sample of 1,500 adults.
Yeah,
Those 1,500 were very carefully chosen on a variety of parameters to match the demographics of the entire U.S. And we didn't know what we were going to find, but we asked people, "Do you have pain or illness that has, and if you do, is it explained or not explained?" And if it's explained, are you getting better in the way your doctor expects you to? And what we found was that 24% of the US population had unexplained symptoms, which are almost certainly neuroplastic, because the average was about that these people had had these symptoms for 4 years. So if there's no
yeah.
explanation after 4 years, it's almost certainly neuroplastic. Then there was a second group,
Wow.
23% of the US population, that said, yes, I do have an explanation for this, but I'm not getting better the way my doctor expects me to with the treatment. And a very large proportion of those people um, also have neuroplastic symptoms. And that's the reason that they're not getting better, is because the treatment is being applied to the organ or the structure, but that's not where the symptoms are coming from.
So, I mean, the implications of this, well, I don't have to tell you, are gigantic because you're talking about millions.
48% of the US adult population. I
Uh,
mean, it's there's 250 million adults in the US.
Now, and this could lead to, I think, and I hope, another conversation, David, in that, because we'd have to then ask, what the hell is going on? Like, why is such a high proportion of our population suffering? And it may well have something to do with modern life, and the fact that we're not designed for the amount of chronic stress, overstimulus, certainly in your country, extreme polarization. uh,
Yes, yeah, there's a lot of truth to that. And we as a species we evolved in relatively small groups. There's
that's right.
sociology evidence that we are most comfortable in a group of less than 150 people.
Yes,
Um,
our mind can encompass the complexity of those relations, but no more.
that's right. And
Yeah.
there's not many of us living in those kind of environments today.
No, we live in like a dozen villages, not one, and those villages can be populated by thousands. So I think that we may have another, if you're open to it, another conversation that actually looks. I'm very, very influenced by and keen on evolutionary psychology and how that helps us understand some of the mysteries of why we're so weird, right? Like, yeah, because I work with a lot of really high performing, highly intelligent people, and then they say, I know this is stupid, but, and I think it's a very similar terrain. It's like people, it's got to do with a certain mismatch between our design features and the world that we live in, and it causes, I think, a lot of chronic suffering.
Yeah, yeah, no question. And then there's the interaction with the childhood adversity. We have,
Yep.
25% of the population has at least three adverse childhood experiences, and we know those have major long-term impact.
Yep.
One that I neglected to mention was many of my patients are so busy taking care of everybody else in their world that they forget to put themselves on the list of people they take care of. So
Yeah.
they're living lives as if on a treadmill they never step off. And
Yeah.
if you don't have the ability to take time or the availability to take time for your own joy on a regular basis, sooner or later that will catch up with you and your body will protest.
Yeah, and I'm sure you've had many patients and have many patients who keep apologising to you for being such a burden and being so slow to get better, and that maybe they should leave treatment because they're so hopeless, something like that.
Well, yeah, and that's the image that many physicians have of these patients is that they're all
Yeah,
neurotic and they can't handle their
yeah,
own stress. But in truth,
yeah,
my patients are mentally stronger than average. I think of them like Olympic weightlifters who
yeah,
have been asked to carry 50 pounds more than the world record for their weight class with
yeah,
respect to the psychosocial burdens that they're carrying from often from childhood or perhaps later in some cases. Anybody's body is going to break down if they're trying to carry that kind of weight. And that's
yeah,
what I find is that people you would never guess, if you were working in the next cubicle over, or if they were your neighbor,
yeah.
you'd have no idea what they were dealing with.
And this, of course, is one of the privileges of therapeutic practice, to being let into the tent, as it were, to what people are actually experiencing on the inside. And like you, I'm just full of admiration at their resilience and their fortitude, their courage. Uh, I doubt I would have that degree of resilience and courage. I mean, I don't know, but
Yeah, I question it myself. How would I respond if I
yeah,
was in the environments that some of these individuals were in? That very first patient, one bowel movement per month, her father sexually assaulted her 400 times between the ages of 4 and 12. But
yeah,
only her husband knew this. She worked half time at a bank. She had two kids. She was happily married. How
extraordinary.
in the world did she do that?
Yeah, yeah. All right, we could, I think, talk for a very long time, but I think we've given the audience, an overview and a sense of If you're open to the possibility, we might revisit this down the track a bit, if that's okay with you, to,
Sure.
to, to maybe drill into some of the issues a little. So I think we've whet their appetite, but I think they might want to just know a bit more about how it actually works, get more of the detail. But for now, well, firstly, I'd like to thank you for the work you're doing. I think it's extremely important. And obviously, I want to thank you for your time. It's lovely to meet you. I'll remind people that they can listen to your podcast, the story behind the symptoms, isn't it? And also the website symptomatic.me. There's a lot on that website. But for now, it just remains to thank you so much, and I look forward to when we might speak again.
Thank you, Chris. It's been a pleasure.
Good on you. You've been listening to the Psychology to Live By podcast. If you like the podcast and want to know more, my website is www.drchris.life. There you'll find links to my various social media posts, a newsletter, and lots more. And share the podcast with people you like so they can like it too.